So today, again, we're going to use some of the concepts that we spoke about, how to look at evidence, and we're going to go over this subject of ventilatory support of the newborn with respiratory distress syndrome. And I had mentioned this paper before from 1959 when they started to look at exposure to oxygen and how oxygen was then responsible for lung damage. And we began to understand the concept that we needed to quantify the amount of oxygen exposure and how it relates to lung inflammation and chronic lung disease. I like to put pictures and to remember people. It's very important for us not to forget who the people that were really groundbreaking in trying to help us understand the pathophysiology of lung disease and in general, all the important pathology that we have in newborn. And so Marilyn Guevara, very important for us trying to understand what the pathophysiology was for respiratory distress, for what pathologists at that time called hyaline membrane disease. And so this was a very important milestone in our understanding of this disease. This slide, I think we can put down the light a little bit. Yes. It is from Dr. Mildred Stallman's laboratory. She we'll talk a little bit about her. She's 84 years old, now going to 85, and she's still doing research where I came from at Vanderbilt. But this is a very beautiful picture of a type 2 pneumocytes, and through exocytosis is eliminating the surfactant from the lamellar bodies into the alveoli, and then forming this very beautiful mesh of surfactant, which is going to coat the inner surface of the alveoli. And these are two very important women. This is Dr. Stallman in the 1960s. She came to Sweden in 1960-61, and she spent a year doing research there. And at that time, they started, the beginning in Sweden, they had already started to put babies on mechanical ventilation. And so she went back to the United States, and then she started to do research at Vanderbilt in 1961 and opened up this whole era of research, and was one of the first women who, as neonatologists, that started to put babies on ventilation in the United States, along with Dr. Papadopoulos from Greece, and she was at the University of Toronto. And just an anecdote, during the time that little baby was born from the Kennedy in 1963, there was a discussion of what to do with this little baby because they didn't have the resources to take care of this baby with respiratory distress. And so the story is told that they had two options. And one was to take the baby and send the baby to Toronto to Dr. Gregory. But they said that that wouldn't be politically correct for the United States to send the baby to Canada, the son of the president to Canada. And then the other one was, well, then send the baby to Nashville, Tennessee. But it wasn't politically correct to send somebody to the South. And so finally they just decided to keep the baby in Boston. But they started off this whole process, very important women. And you can see Dr. Mildred Stallman doing pulmonary function tests on babies. She then worked on that model with a lamb with a window where they were able to put catheters in and get blood gases for the lambs. And so how many of you remember this? Okay. There you go. So this is how we started. And so when they started to put babies, some people asked, what was it that they put the babies on? Well, we put babies on adult ventilators, and this was the first ventilator that we did it. And the name, the bird, comes from a pilot from the Second World War, who was a man that at that time during the Second World War was doing research on how to help people breathe at very high altitudes. And when the Second World War ended, he didn't know what to do anymore with what he had learned. And so he said, well, I'm going to try to apply what I've learned to help people who have problems breathing. And so that's how he developed this first ventilator. And then after that, he developed the baby bird, which, how many of you used the baby bird? Putting it together was a very interesting thing. The green hoses and the red hoses, but it was the first baby ventilator that was appropriate. At this time, when this started, we didn't use PEEP at all. Very important, we just used peak pressures, but we did not use PEEP on these patients. So we'll get to that. So, of course, we were able to increase survival. And we increased survival at the expense of increasing morbidity. But it was, at that time, better to improve survival and accept morbidity. But we started to learn about the damages that we could produce. And X-rays like this, we had babies where we had 3, 4 chest tubes on both sides, and many of these babies were exposed to high concentrations of oxygen, and of course we produce a lot of barotrauma. The important thing is, because everything changes, we're located at a time where we did not have surfactant and we did not have prenatal steroids. And I think that that's very important for us to keep in mind, because now we're at a different era where we have the post-prenatal steroids and post-surfactant era, and patients are not the same as they were at that period of time. So again, you have seen this as a result of the studies that were done. This is Dr. William Northway, a pathologist who was key in trying to look at all the different findings that they were seeing in the pathologies of the lungs of these babies that were exposed to mechanical ventilation, high concentrations of oxygen, and you know all this very clearly. So then came the era where we, in 1982, began to look at a model that could be reproduced of chronic lung disease. And Jackie Colson and their group did this using the baboon. Marilyn Guevara was a fellow at Vanderbilt also who trained with Dr. Stallman. And they were able to take what we did with babies on mechanical ventilation and expose the baboon to the same type of settings on mechanical ventilation and then reproduce the same type of changes. It became one of the best models for looking at, from an experimental perspective, lung disease. And then this paper in 1987, so we're moving up in sequentially 1987 by Dr. Marilyn Guevara, was a very interesting paper because she looked at different neonatal units, and her question is, what she tried to answer is, chronic lung disease in low birth weight infants preventable? Is there anything that we can find about how people do things and how they care for babies in different institutions? And one of the things that you will see with chronic lung disease, and the difficulty with chronic lung disease, has to do also with the way we measure chronic lung disease. You know, when you do a research project, you have a question you want to answer, and you apply an intervention, but then you want to measure an effect of that intervention. And the ideal thing is that if we could have something like weight, that you had computerized scales where you can put a baby and have an exact weight of the baby, that's a very exact measurement of that variable. And the better, the more exact that measurement is, the better the results of your research project. Well, with chronic lung disease, we've not had that at all. And we're still struggling with it because we use definitions. And so definitions are arbitrary definitions. And so during this time, we were using for this was oxygen dependency at 28 days. And then we modified the definition and we said 28 consecutive days of oxygen dependency during the first 60 days of life. And then we went to the definition of 36 weeks post-conceptional age. And now we're looking at the physiologic definition. And every time we change our definitions, our incidence go up or go down. You can manipulate your instance in your institution by using different definitions for chronic lung disease. And so that's the inexact and subjective aspect of how we look at chronic lung disease. But with this definition that they used oxygen dependency at 28 days. One of the things that they were able to see was when they compared all these neonatal units in the United States, 8 NICUs, there was one unit here that was had the lowest incidence. And of course, from an epidemiologic perspective, it's always very interesting to find that there's something like this. Why is this so different to the rest? And they looked in more detail, and that was that famous unit from the Columbia Presbyterian Hospital in New York. And she looked in more detail to what was it that they did with their babies. And they had the lowest rates of chronic lung disease even after controlling for birth weight, race, and sex. And what they used was their early CPAP of 5 centimeters of water, which was initiated in every infant with respiratory distress, independent of weight. And what they found also that 50% of newborns were placed on CPAP in the delivery room already. So nothing new. What we're doing here and what we're talking about was being done in the 1970s by that group. So that was happening in the delivery room. 42% require subsequent intubation and mechanical ventilation. So they realized that, yes, you could decrease significantly the use of mechanical ventilation, but there were babies that were going to require mechanical ventilation. And so the key thing is what population and how would you define that population to identify those that were going to require mechanical ventilation. And this picture is a picture of Dr. Gregory. So he began to do his research. He's an anesthesiologist, not even a pediatrician. And what his issue was that every time he went past his NICU, you would hear that there were babies that were dying in respiratory failure. And they would sit down and they would talk to each other. And he says, we have this problem. These kids are dying of respiratory distress. And at that point in time, there was some research that was coming out of Europe and that came talking about what the interpretation of what a baby was doing when the baby was grunting. And he read this paper, and with that paper, they started to speculate what did that mean, and they came to the conclusion that the grunting was a process of what the baby was trying to do with the larynx, closing the larynx to prolong expiration and to maintain pressure in the lungs. And so he took an anesthesia bag and he created a device within the anesthesia bag that you could manipulate the expiration and then put a PEEP on it. And then he applied that. He said, well, I can do something. Let me see if this works for your baby. And he took a couple of babies, put them on that apparatus, and the babies survived with respiratory distress. And then he published what he had observed, and it was, of course, the first system for CPAP. And this is what Columbia Presbyterian was using in 1976. Very simple, you have a blender with a source of oxygen going into a cascade, and then you have the inspiratory limb and the expiratory limb that was going into a jar. And we used this system in the 1980s when we did not have ventilators for some of the babies. And so it was very easy to set up. But that's basically the same system. It's been upgraded at Columbia Presbyterian, but it's basically the same concept. And so with that, they were able to show that you could save babies who had respiratory distress in them. This paper now is, 1988, European Journal of Pediatrics. And there's also a story behind this. The person who developed surfactant was a person that was in the United States doing research. And then his grant ended and he couldn't get a bridge grant. And so he couldn't stay more in the United States. So he went back to Japan, and then over there he was able to develop and produce the first surfactant and then do a randomized controlled trial of surfactant. And these were people that were thinking of basic things and how, trying to understand what Dr. Marilyn Guevara in the past had come up with that thought process of that absence of surfactant. Well, he made this possible, first randomized control trial, and they were able to see that there was decreased mortality and from respiratory distress by applying the surfactant into the airway. And now we're here, and this is a very interesting graph because it summarizes what's been happening with lung injury in our preterm babies and what's been happening over time. And one of the most important aspects of this graph is that we're taking into account all the embryology and the development of the lung and trying to understand what was happening. When we talked about the Kennedy baby, we were talking about babies that were being born in the alveolar phase of lung development, so those 32, 36-week babies. And so the treatment for these babies were developing severe chronic lung disease. Those are the x-rays that I was showing. We were producing a lot of barrel trauma for these babies. The advent of surfactant. Yes, people say, well, surfactant didn't really show that you could decrease chronic lung disease. Well, it depends on where you're looking at the problem. If you're looking at babies that were born during the saccular phase and trying to look at what surfactant did, you might not find that effect. But if you looked at the effect of surfactant in babies that were born during the alveolar phase, yes, definitely it decreased lung damage. We don't see those babies having severe chronic lung disease anymore. It's not that those babies have changed in the last 50 years. They're the same babies, but they were being born during this phase of lung development. They had alveoli. But with ventilators and the new technology, we were able to move everything back, and now we were having babies being born in the saccular and, of course, at the end of the cannulicular phase of lung development. And then we had all these factors that were now being included into how these babies were being taken care of. And we had prenatal factors that could influence the development of the lung, like the presence of chorioamnionitis, how it affects the fetal lung, the use of antenatal steroids, which then came after 1989, 1990, very shortly after surfactant. And then you can see here, of course, the effect of mechanical ventilation, the exposure to oxygen, and all the different aspects that could lead to lung injury. But it was very different to be exposed to mechanical ventilation here. It's very different to the effect of being exposed to mechanical ventilation in high oxygen concentrations here. And we've all learned that in the past, I remember many of our meetings, we were very hopeful that all our babies with chronic lung disease, all we needed to do was to nourish them well, because from our embryology we learned that lung development continued to the age of 2. But then we had the autopsy reports of those babies that we were managing at 27, 26 weeks, and many of those babies, when they died 3-4 months afterwards with chronic lung disease and pulmonary hypertension, many of those babies' lungs did not develop at all, and they stopped their development. And even if we nourished them well, we weren't doing a good job in making those lungs grow. So it was something we believed in, but it was not happening. Of course, right now, everything is in question with how we nourish babies, and the new research that's coming out is we might be producing damage to the babies with the way we give them our parenteral nutrition. The soybean-based parenteral nutrition is a pro-inflammatory. That produces inflammation, and that's why people are now looking at the possibility of changing that soy-based parenteral nutrition to fish oil and other ways to decrease. Fish oil is an anti-inflammatory. If you have a baby that's premature, you expose them to high concentrations of oxygen, and you're nourishing them with a soy-based parenteral nutrition, you could be producing more lung damage. And so a lot of the research is going to go into that area. But this is, again, very important to look at. These papers came out now in 1989, 1990. Animal models where the experiments just showed taking premature lamb or rabbit and then exposing that animal to a couple of positive pressure ventilations with peak pressures of 40, 45, and then looking at the pathology of those lungs. And they demonstrated with that, using the anesthesia bags, we could quickly produce damage in the lungs. And so in our units, we had these green anesthesia bags with a little blue valve that you can manipulate for CPAP. But you could see that sometimes while they were taking care of the babies, somebody would turn that blue valve, and suddenly you would have a bag that would inflate. And suddenly a baby would get a PEEP of 15 or 18. And somebody was putting pressure, and the pressure would go up to 60. And this was a 25-weeker, already you would have done lung damage. And you would take those babies into the NICU, and then first x-ray, and the baby had pulmonary interstitial emphysema on the first and second x-ray. But what was happening is that we had already produced the lung damage in the process of resuscitation. And so the advent of the Neopub, that T-piece resuscitator, where you can then set your peak pressures and try to standardize them, and you change them depending on what's happening with the child, that's changed the way we've practiced. We've taken away the anesthesia bags. We did some research that showed that while you are tense and you're trying to resuscitate a baby that's not doing well, you think you're doing good pressure with your anesthesia bag or your self-inflatable bags, and we documented people giving 50 and 60 of pressures when they thought that they were giving only 20, 25. And so there is a lot of variability, but we did find out that just giving positive pressure ventilation could produce lung damage. And then they did all these very interesting experiments with the rabbits where they put a belt around the chest, and then they gave high pressures, and they found out that it wasn't the pressure really that produced the lung damage, but it had to do with if you took the belt off and then gave the same pressure, you would produce more lung damage, and the concept of value trauma came into the picture. And so value trauma, very important. And then the third one was the atelecto trauma, and that came from research that was very interesting because what they did to simulate RDS was take lungs from animals and lavage the surfactant. And one of the things that they noticed in the pathology looking at those lungs is as soon as they took out the surfactant and they looked at the pathology, all the lungs were filled with neutrophils. But those neutrophils were there, but they were not producing any inflammation. But when they started to manipulate the volumes of those lungs and they decreased the FRCs until there was atelectasis, then there would be this liberation of cytokines within the lungs. And so we learned about atelecto trauma, that we could produce atelecto trauma, and we had that experience with many of the babies that we gave surfactant, and we started to quickly decrease the pressures. And suddenly, when the baby was doing very well and we decreased the pressures, a couple hours after that, the babies were requiring, again, we had to go back up on the pressures because the babies started to have more lung disease, and we didn't understand why. And so that's part of all that learning process, and we learned that to be able to ventilate babies on any type of ventilator, that didn't matter what it was, high frequency, if it was the jet, the oscillator, or conventional ventilation with any mode, we had to be ventilating this babies in this part of this pressure volume, and that if we went above that, then we would be producing volume trauma, and if we went below it, we would be producing atelecto trauma. So the art of ventilating a baby had to do, how do we stay in this area all the time, and that was very difficult, especially when we didn't use volume ventilation and we didn't understand, we used to quantify it mathematically, but we didn't have ventilators that had screens that showed us how much tidal volume we were giving the babies. I think that in our time, having that capacity to look at tidal volumes and calculate really has decreased significantly the amount of volume trauma and atelecto trauma that we used to have in the past. And so this paper from Jackie Colson's lab and her group there, neonatal chronic lung disease in extremely immature baboons, was now a step forward. They were able to take a model for baboons that were delivered at 27, 28 weeks and reproduce exactly everything that we did with those to look at what happened to their lungs. And now we're talking about post-prenatal steroids, post-surfactant era. And so this is what they gave. They gave the mother's prenatal steroids, then the infants were born prematurely, they got exogenous surfactant, they were ventilated for 1 to 2 months, lower concentrations of oxygen, we learned that they were managed with lower concentrations of oxygen. And here, these are controls at 125 days term plus 2 months, and very nicely you see this 125 premature lung. The interstitial space is very thick. It's very important because we'll see as development goes, it is from that with these growth factors that interstitial space becomes more narrower, and then you have formation of septations. But you hardly see any septations, they're just beginning. But this is the normal lung at that time. At term, you start to see septations, where you see these little crests starting to form in different areas. And this is a mature lung with a lot of alveolar formation and very nice septation. That's shown with the arrows. In the babies with chronic lung disease, in those animal models, baboon models of premature baboons, then you can see how the anatomy is distorted. These are animals that were ventilated at 71 days, 30 days, and 39 days survivors. And you can see that the most characteristic finding is that you do not have adequate septation. So that's where we learned septation. Something is arrested. Septation is, and the formation of alveoli are arrested. And here, this one, where it's even worse, but then you can see that it's very hypercellular. What was happening with these animals was that these animals were getting infected. And when they got infected, then lung damage was worse. And so here comes that multifactorial part of it, where you have exposure to oxygen, you have all the inflammation that's produced from that, you have ventilator-induced lung injury, and then on top of that you have an infection, and you've already set up for having a baby with severe chronic lung disease. So if in your units you could decrease infection, you could decrease the severity of lung disease. But that, again, is a pretty big challenge. And here, this is a 45-day survivor with chronic lung disease. And basically, just wants to emphasize on electron microscopy how septation is blunted completely. And then, of course, when that is blunted, your formation of alveolar is also affected. And elastin deposition, it is inappropriately, its location is altered when you are exposed to mechanical ventilation, and it does not favor also septation. So Linda Van Marter, a neonatologist and clinical epidemiologist, also published this paper, and she basically, her question was, do clinical markers of barotrauma and oxygen toxicity explain intra-hospital variation in rates of chronic lung disease? So she went back to Marilyn Guevara's paper, and then she said, well, I'm going to compare, you know, the Boston unit, the most important unit there, and the Columbia Presbyterian, and here's what she showed in this observational study. Mechanical ventilation at that time, that was the main, that's how they took care of babies with respiratory distress. CPAP was used, but mostly for extubating babies. Surfactant, 45%. Duration of mechanical ventilation is on average, this was the median, 27 days. And according to their definition of chronic lung disease, 22%. When she looked at the Columbia Presbyterian, the same thing persisted. You know, 29% only got mechanical ventilation, and that was because mechanical ventilation here was used as a rescue therapy for babies that failed on CPAP, which was the primordial way of managing these babies. 10% surfactant, they give less surfactant, and they give rescue surfactant. They continue to give rescue surfactant today. They don't give early surfactant. And duration of mechanical ventilation was 13 days, and of course their incidence of chronic lung disease was lower. And so some support from that, what they did, some more statistical analysis, and through logistic regression, they found out that initiation of mechanical ventilation was associated with the development of chronic lung disease in that study that she was doing. And that the odds ratio for chronic lung disease when mechanical ventilation was initiated at birth was, if you were exposed to mechanical ventilation, you had 13.4 times more the probability of developing chronic lung disease if it was initiated at the time of birth. And if it was initiated between 1 and 3 days of life, it was 9.6 times higher, the incidence of chronic lung disease. And if it was initiated between 4 and 7 days, and then chronic lung disease went up 6 times, it was 6 times higher. So now looking at risk factors, which is one of the important things of doing these studies, doing prospective cohort studies. This is retrospective, but it helps to give an idea that then needs to be taken and proven in randomized control trials. This information was very important for that. And so mechanical ventilation, very, very important. This paper came out from Alison Viget, and she she used the Lamb model. And her thought process was, okay, it's multifactorial. Chronic lung disease is multifactorial. But let's try to eliminate all the different variables and let me just focus on mechanical ventilation. How can I do that? So that I take away oxygen as a variable, fluids as a variable. And what she did was, through this Lamb model, she used that window model that Dr. Stallman had used a very long time ago. And she basically did a lung lavage on the fetus in utero and taking out the fluid, then intubated these fetuses and gave positive pressure ventilation in room air, and then sacrificed the animals and looked at what was happening with the lungs. And so she eliminated the other variables. And what she found in that study was that, yes, in the summer you already know what the anatomy of the controls and normals are, but the same situation with septation and formation of crest and septation was produced without any exposure to oxygen, just by exposing that fetus to intermittent mechanical ventilation, what we would use as conventional ventilation. So that can be reproduced just by that exposure. And then, of course, increased deposition of fibrin, collagen, fibrosis of the lung was demonstrated in that study. Alan Jobe, who's been very interested in looking at this, also did experiments in lambs, and he now wanted to test the CPAP and how, if he could minimize what they were seeing in these animal models with mechanical ventilation. And his concern is decreasing the cases of lung injury with continuous positive end expiratory pressure. He used premature lambs that were delivered at 133 days of gestation, so something like 26 to 27 weeks gestation in humans. The randomization to CPAP, 5 centimeters, to mechanical ventilation, as you see here, and no ventilation, 3 groups. And this is the way they treated the ones that were on mechanical ventilation. Very similar to how we would treat a baby with respiratory distress, at least how we were doing at that time. Today we're tolerating a little bit higher CO2s in these babies, in the 45 to 55 range. But otherwise very similar. And after 2 hours of intervention, the animals were sacrificed and lungs were extracted for alveolar lavage and measurement of different cell inflammatory markers. And so the first thing that you looked at is that concept of neutrophils, what happens to the lungs. And so only here we can say, well, from that experiment, doing the lung lavage, just that stimulates the movement of neutrophils to the lung in some of those experiments that I talked to you about. But very interestingly here, after ventilating, and this was the group that did not have any ventilation, and this was the group that had CPAP, comparatively, those that were exposed to mechanical ventilation had 7 times more neutrophils in their lungs than those that were on CPAP. And so just the stimulus of stretching the lung from peak to peak pressure was sufficient to have this observation. And then he looked at also hydrogen peroxide as a correlate to inflammation in the lung and also oxidative stress. And he found that it was significantly lower in the CPAP compared to the mechanical ventilation, and that was statistically significant. Pulmonary compliance measured through pressure volume curves was superior in the CPAP group, and it was significant in that animal model. And so his conclusion was that this study shows that bubble CPAP protects the lungs and may lower the risks of chronic lung disease. Avoiding over or underinflation of the lung may reduce repeated inflammatory injury. And so there was some base for what they were saying. Now, take into account that we're looking at short-term outcomes. And this is where we have to be critical of how we look at all this information. We're all looking at short-term outcomes, so we have to be careful that we're not looking at the big picture of long-term, what happens to all these animals when they're exposed to long-term to this. Marilyn Thompson, this paper came out in 2004, treatment of immature baboons for 28 days with early nasal CPAP. And again, you already know how a nice lung 125-day control looks like, and 156-day control with all these beautiful septations all through the lung and alveolization. Well, this was the CPAP survivor at 28 days, and this is what the lung looked like, exactly like the lung of the control groups who had not been exposed to mechanical ventilation. CPAP was very protective of the lung. And so we know that if you let a baby breathe spontaneously and generate its own negative pressure, and you can support them with end expiratory pressure to overcome respiratory distress syndrome, those, those babies maintain that same type of anatomy that you would see in this animal model, where there is no damage to that septation, even in a premature animal. And so somebody asked the question about cerebral blood flow and how this has been, types of ventilation are affected. And this was done with 33 xenon clearance, looking at cerebral blood flow in milliliters per 100 grams per minute. That's how that was done. And they took non-respiratory distress babies with respiratory distress and mechanical ventilation, and respiratory distress and CPAP. And here you can see that this is the normal cerebral blood flow with this technique, and how it goes down when you go to mechanical ventilation. It's close to a 50% drop in cerebral blood flow. And you go back to CPAP, and it goes back to close to what it was when it was no respiratory distress. So putting a baby on CPAP and putting a baby on mechanical ventilation does affect your cerebral blood flow. We've never studied that. We've never even looked at that. And that's why the long-term effect has to be evaluated, because if we could demonstrate that if something like this would just stimulate a randomized control trial looking at this to see if the developmental outcome of the ones exposed to mechanical ventilation versus these exposed to CPAP is better in one or the other group. That would be an interesting question to ask. But of course, I think that in these two groups would need surfactant, early surfactant on both sides. This is another study that was in 2009 with a different technique that they used for cerebral blood flow. And again, what you see, they looked at high-frequency ventilation and how significantly that decreases, SIMV and how that decreases, and then nasal CPAP. With this technique, what they found was the cerebral blood flow was even higher than what it normally is for a baby that's breathing spontaneously. So that's something that has to be looked at more carefully, because if with CPAP we're increasing the cerebral blood flow above baseline on a spontaneously breathing baby, does that have any effect? Does that have any risk, for example, for intraventricular hemorrhage? And so, again, we do not have any information on this. It's not been studied appropriately, and I think that it's worthwhile looking at this. But again, the question over here also is, if you have a baby being managed on high-frequency ventilation from the first day and they're premature, and you know that their cerebral blood flow is significantly lower, does this affect your developmental outcome at 5 years of age? So, another concerning aspect of this. Yes?
Are the CO2 levels similar in the three groups? Because that's what determines, I think, cerebral blood flow, isn't it? It's the CO2. You can imagine on CPAP you've got higher CO2 levels. That might be the explanation.
Well, yes, there was variability in those CO2 levels. But that wasn't looked at clearly, so that is a variable that when you looked at those papers, that might have been a very good critique for that paper. Because we do know in general that if you were at Columbia Presbyterian, let's say you took babies from there and you looked at their CO2 levels we're talking, let's go a little bit back to the prenatal steroid era. Then many of those babies might have had their CO2s at 85. So what they did at Columbia Presbyterian was that the baby had respiratory distress. They didn't care about the x-ray. They knew the baby was premature. They put them on the CPAP from the beginning, and all they did was look at their saturations. If the baby could be tachypnic, they could have taken the x-ray and said, oh, this is severe RDS. But if the baby was hemodynamically stable and maintaining their saturations of 100, they didn't care about the CO2. But when they started to measure the CO2 in those patients, even though they maintain 100%, their sats in good saturation, it was around 85, 80, the average. So the question is, nobody's really looked at what a CO2 of 80 does. Yes, and it could be affecting, yes. But again, with very premature babies, autoregulation of cerebral blood flow is not adequate. So that's another variable that you have to look at, because depending on how premature you are, your autoregulation is worse, and you can have much more fluctuations in blood flow and cerebral blood flow overall. And so it's very interesting that's a variable that you have to look at more carefully. Most likely on the ventilator, if you're on high frequency, you were having it on the lower side. And so that's something that you needed to control for. Exactly.
Excuse me, how many kilopascal does 80?
I cannot, I don't know. You can help me with that because you use kilopascals all the time.
7.5.
The computer can help. You can type in there in Google, what does it account for? Okay. So now let's look at randomized controlled trials. And so let's look at the evidence in more detail. Dr. Salvador Navarro has given you an overall view of this, but we're going to do more nitty-gritty look into the details of these studies. And so what I'm going to take you to the pre-surfactant and pre-prenatal steroid era. And so in 1976, we had 2 interventions to manage respiratory distress. And so it should have been in 1976 where they should have done that randomized controlled trial in these things. We shouldn't be doing these trials, in 2010, 2005. That should have been done at that point in time. But this is a trial that should have occurred at that time. Preterm infants with respiratory distress should have been randomized to nasal CPAP and mechanical ventilation. At that time, we were not going to look at developmental outcome because we didn't think that was we didn't know how to measure that, and we didn't have that understanding. But we would have looked at most likely mortality, which was the big issue at that time, air leak syndrome, and chronic lung disease, which was we knew we had at least a definition and a clinical pathological correlation. But this study was never done. Why do you think this study was not done? And so the group in Columbia Presbyterian said, this is the best way to do it. Our best treatment for RDS is CPAP, and we feel that it would be unethical for us to participate in a trial where we expose babies to something that's inferior, which is mechanical ventilation. But if you went to Boston, and then in Boston they would have said, CPAP? No, our best treatment is mechanical ventilation. And this is the best way to treat babies. We can't participate in these trials. And because the proposal was there, and it never happened because of this. But again, this is the typical example that if they went and looked at the evidence, which was lacking, absolutely lacking at that point in time, they would have been able to reach equipoise and say, well, the information is not good. Let's do this randomized control trial. We would have had that answer a long time ago. And maybe it would have come out to be very interesting because imagine without surfactant and without prenatal steroids, maybe the advantages of CPAP might have been more evident at that point in time, at least for chronic lung disease. And they might have said, oh, with CPAP you decrease significantly chronic lung disease while improving survival. But our minds don't, we just couldn't get that. We weren't able to do that because we did not have equipoise. And so that's why I bring this question, because today we still have to ask ourselves, do we have equipoise or are we biased with inadequate objective information? And so the early post-surfactant era, we're going to go to the early post-surfactant era. And we have preterm infants with RDS. They're not the same preterm infants as we mentioned, because now we're moving down that gestational age, and it's not our 32, 34, 36 weekers. Now we're having the 28, the 27, and it's a different time. But you had this trial that was done, mechanical ventilation alone with mechanical ventilation with surfactant, which was the Japanese trial, mortality, air leak, chronic lung disease. At this time, we could have looked at developmental outcome. Well, the majority did not look at that because they were looking at the short-term outcome. And the short-term outcome looked good. Yes, morbidity started to decrease. We couldn't demonstrate a decrease in the incidence of chronic lung disease. And so our hypothesis is, why couldn't we demonstrate that surfactant could decrease it? And one is because of the type of population we were managing, the more premature, where there's lung arrest and development. But another factor is that we were still using mechanical ventilation, which is a major risk factor for chronic lung disease. So that's a hypothesis. That's a speculation. We don't have proof of that. And then in the early post-surfactant era, you would have had preterm with RDS, you would have nasal CPAP alone, and you would compare it to nasal CPAP with surfactant. And that should have had happened at the same time that surfactant came out in 1988. 1988, 1989 would have been the perfect time to have done this trial and answered this question. But it was not done because CPAP was put to the side, and the only one that was doing CPAP was Columbia Presbyterian, and they were consistently showing that they had decreased chronic lung disease, and that was their standard of care. But this is a trial that should have been done at Columbia Presbyterian, because they didn't have to change nasal CPAP. They had equipoise saying that nasal CPAP was okay, it was good, that was their treatment for RDS. But now there's a new intervention, surfactant, and it correlates with the pathology that Dr. Mary Ellen Avery began to have discovered the deficiency in surfactant. So why not do a randomized control trial with nasal CPAP and nasal CPAP with surfactant? It didn't happen. And why doesn't it happen? Because there's no equipoise, because you're not really looking at the evidence. And if you looked at the evidence and you would say, well, with surfactant, without surfactant, no, we don't have anything there. Let's try that. Maybe we find out that the outcomes for these babies are better. It wasn't done. And then now we go to the late post-surfactant and post-prenatal steroid era. These babies are born different. Our babies are different now. We had the experience of doing trials in South America and looking at what was happening here. Here in the United States at one point in time where we were in the different institutions, 85% of mothers were getting prenatal steroids. If you went to a developing country, you might have 25% of the mothers or less having prenatal steroids. So the way you did your trials could make a big difference depending on that just different characteristic. Because many of those babies that we had in the 80s and 90s that were born with severe, early 80s, late 80s, just before surfactant, those babies were born with severe respiratory distress syndrome. And so the concept of prophylaxis came into play. And I think that prophylaxis was an interesting concept at that point in time because the majority of those babies were the severe ones. But now we're in the post-prenatal steroid era, and then you want to use the concept of prophylaxis, and it might not fit in adequately because now those babies, many of those 26, 25, 27 weekers are being born with agars of 8 and 9. And many of those babies, you look at them and they're breathing spontaneously, and they might not even require a high-flow nasal cannula. So by protocol, if you have your protocol, every baby less than 27 weeks has to get intubated and has to get surfactant, has to be placed on mechanical ventilation, and has to be getting central lines, umbilical lines. Well, you're going to be putting in the post-prenatal steroid era a lot of babies to multiple interventions that they might not need at all. And that's been one of the things that we've been trying to change in our NICUs. And so as neonatologists, we're now going into the delivery room to observe what's going on. And we say, well, this baby is 26 weeks, but the APGAR was 8 and 9. Does NRP tell you that you have to do all these things that you're going to do to this baby with these APGARs? No, but the protocol says that we do prophylactic, and so that's why they do it. And what we're trying to tell them now, there's a judgment call now, because not every baby is going to be born like that. There are babies that don't get prenatal steroids. And we have a lot of immigrant populations that don't go to the hospitals until the last minute, and they're born and they don't get their prenatal steroids, or they just get one dose. And many of those babies look like the babies that we had in the 80s. If you go to a developing country that doesn't have the resources, or from a public health perspective, mothers are not getting steroids, you will still see those babies. And then maybe the prophylaxis in that situation might be better. But of course, the resources might not permit that surfactant be used prophylactically because of the cost. And so that's what we learned when we start to do international collaborative research. It's been a wonderful part of what I've learned moving back and forth between countries and looking at this. In this late post-surfactant, post-prenatal steroid era, you see here these studies, preterm infants with RDS, nasal CPAP alone, SIMB with early surfactant. And I can understand why they do these trials, because they're trying to compare what Columbia Presbyterian is doing to what other units have been doing for a long time, which is mechanical ventilation and early surfactant. But I believe that this, in 2012, where surfactant has proven to be very efficacious and safe, and that the earlier you give the surfactant, as Dr. Navarro had been showing us, this arm should always include early surfactant. But people get into complications about this, but because they say, oh, you have to intubate these babies. But take away mechanical ventilation and think about what the primary problem for these babies is surfactant deficiency. So my concern in the delivery room is not whether I'm going to put the baby on mechanical ventilation or CPAP. My concern is, oh, what does this baby have? Oh, respiratory distress syndrome, all the premature, and has all the symptoms. This baby needs surfactant. And so what I need to do is put the surfactant into that baby and then decide what type of ventilation I want to give. And I might say, well, I want to put them on mechanical ventilation. It's fine if that's what you want to do. Or I want to put them on CPAP. Okay, that's another alternative. But the main thing is that these patients are surfactant deficiency, and we have a treatment that's safe and efficacious, and we wanted to give it earlier because we know that the earlier, and there is a Cochrane review of that, the earlier you give surfactant, the better the outcome for these babies. But so I'm not going to go over this. I'll go over this very quickly. The COIN study, again, was a study that looked at prophylactic surfactant plus mechanical ventilation. Their standard protocol on mechanical ventilation. And then exposed babies, on the other hand, to CPAP of 8 without surfactant. And so somehow there was going to be a disadvantage for this group. And it was shown in the incidence of pneumothorax that we mentioned, which was 9%. And they really didn't find a big difference in oxygen dependency at 36 weeks. It was lower, but it was not statistically significant. And this could be, it could have been, it might have been an issue of power of the study to demonstrate that, but they weren't able to demonstrate that. So again, this would be the comparison between Boston and Columbia Presbyterian. But look at these studies. This is a summary of some of the Verder studies from 1994, 1999, and 2004. There was a lot of variability in gestational age, 25 to 35, less than 30, 29 to 35. Time and hours where surfactant was administered could be given between 2 and 72 hours. In this study, half an hour to 72 hours, any time between. It was rescue. And in this study with Verder, he gave an earlier dose of surfactant, and comparing this study to this study, this babies in this study with earlier surfactant did better. The numbers were very small. These are the control and the treatment groups, 33 and 35, 27, 30, very small numbers. But they all showed a trend towards a decrease in the need for mechanical ventilation. And there's variability in the success rates between the control and the treatment groups. The treatment groups were all much less than the control groups. So that trend was significant through all these. And Dr. Verder's work and Dr. Renninger's work led us also to do our study, the one that we did in Columbia, an international collaborative study. At that time, I was working at the University of North Carolina. And this was an unblinded, multi-center, randomized control trial. And our design of this trial, we used 32 to 27 weeks. Why didn't we go lower than that? Because one thing is that our survival in Colombia for babies less than 27 weeks was very low. And so all those babies got intubated, and they all got surfactant, and they all got lines, and they weren't willing to put those babies at risk in that trial. So we limited it to babies that were 27 to 32 weeks gestation. And they did get antenatal steroids, like 75% of the population was getting prenatal steroids. And then they had the early control group, which was the nasal CPAP with the rescue surfactant, and the nasal CPAP plus very early surfactant, which was given within the first hour of life. So why did we use this arm in Colombia? We use this arm in Colombia, South America, because we don't have access to surfactant all the time. And that's a different issue because many people first don't have access to a ventilator. And as a resident, we had experiences where we had babies, only 6 ventilators, and we had 7 babies with respiratory distress syndrome. And we didn't have anywhere to transfer babies. And so not having surfactant and not even having access to ventilators is a limitation in developing countries. And so we felt that we needed to test also CPAP alone to see if it was an alternative for countries where it had limited resources. So our decision to include it was very different than comparing it to Columbia Presbyterian. That was not our objective in that study. And then we looked at the need for mechanical ventilation as a primary outcome, and again, because of the limitations of having mechanical ventilation in many of the hospital centers in Latin America. And these were our secondary outcomes. We looked at all these different outcomes. And this was the system that we used, the bubble CPAP system, very simple. And we used a T-piece resuscitator. And we used these same parameters for the resuscitation of all babies as a startup for all our babies, and a pressure of 6 centimeters of water. And it was done in the delivery room. This is pretty much the setup for that. And what we did was at birth, 15 minutes resuscitation, stabilization. If a baby got intubated in this period of time, the first 15 minutes during resuscitation, the baby was eliminated from the study. And if the baby did well, then we would look at 15 to 60 minutes if the baby had any increased work of breathing or any need for supplemental oxygen. And that's how we did it in this protocol. We're now looking at our institution and trying to bring back this Silverman evaluation for respiratory distress. How many of you used that before? The Silverman, from William Silverman. He developed that, where you look at the baby and you look at retractions and yes. And so we're trying to bring that back because that's a more objective way to saying if this baby has truly work or breathing, because people vary depending on what they call mild, or moderate, or severe increased work or breathing. But here, any type of increased work or breathing plus the need for supplemental oxygen during those 15, 16 minutes, those babies were put on CPAP, and then the envelope was opened to say surfactant yes, surfactant no, and when they were surfactant yes, they were intubated, given the surfactant, ET tube was pulled. We did not give any sedation or anything. We just intubated the baby like we would do in the delivery room. And we gave the surfactant, then pulled that and put the baby on CPAP. And then followed both groups to see which babies were going to have respiratory failure. And this is the important thing of when I told you to not compare apples with oranges. You have to look at the methodology because it varies. Our population is very different, and I'll show you from other studies. But it also is different in our criteria for considering treatment failure. For our babies to fail CPAP and for us to take the baby and put them on a ventilator, they had to have an FiO2 of 75%. If you did a study where you did it at 45%, you would have a lot of failures. If you did it at 55%, like the other studies were done, you would have much more failures. These babies were, if they required greater than 75%, and those babies had to have, of course, normal saturations. They could have increased work of breathing. They could have saturations that were 100 and looking good, and we kept them there. If they went up to 75, we'd keep them. If it was greater than that, then that would be a criteria. Another one, if your saturation of 80% was persistent, you took the mask, you cleaned the nose and repositioned it, but the baby still sat in the 80s. For 30 minutes, you were doing that, then the baby got put on mechanical ventilation and got surfactant as part of the protocol. Our PO2 tolerance greater than 65. So 65 and above, we were putting those babies. We didn't wait until they were 85. We discussed this issue about the 85, and nobody in our all our neonatologists in Columbia said no. We would not tolerate what Columbia Presbyterian does. If they go to 65, then that's it for those babies above that. And a pH less than 72, but you had to have evidence of progressive increased work of breathing. And this is how we calculated our sample size. Reduction in need for mechanical ventilation from 50 to 30%, a 20% drop in that. And those were our results. I'm just going to show you the positive results here where we showed that if you were in a control group, 39% of the babies would end up on mechanical ventilation. And that's not terribly bad if you were in a place where you don't have anything else to take care of a baby with. That's very good. If you don't have CPAP, then of course all you have is nasal cannula. If you go to World Health Organization, the WHO, and you look up respiratory distress, how do you manage it? They only have nasal cannula and flow. And so if the baby gets worse, you go up on the flow. If you don't have anything else, that's it. That's the end of that baby. And so CPAP becomes a very important tool to be able to decrease mortality from a public health perspective. And that's why we think that this is not bad. But if you give surfactant, then you lower that to 26%. And you can see the RA showing the narrow confidence interval. So for us in developed countries, it's very important that concept that you can really only 74% of the babies are going to require, are not going to require mechanical ventilation. Only 26% will require it. And remember that from the study of Columbia Presbyterian, they were talking about something like 45% required mechanical ventilation. Well, surfactant can decrease that even more. And when we looked at air leak syndrome, we had that same 9%. So you have a study in Australia and Australian Columbia that's telling you that if you have respiratory distress, talking about respiratory distress, not if you do it prophylactically, if you have respiratory distress, that's when you have a higher risk of pneumothorax. When you have respiratory distress and you have VQ mismatch and you have insufficient areas of hyperinflation and underinflation, and you put a baby on CPAP, the risk for pneumothorax is 9%. Now we have that number to quantify and tell people, well, if you have RDS, you put them just on CPAP without surfactant. There are two very good randomized control trials that are showing that 9% pneumothorax. And what are the consequences of a pneumothorax? And we know that that can increase intraventricular hemorrhage, bowel trauma, need for chest tubes, pain for that baby. Chronic lung disease, you can see we dropped it by 10% in the overall population. It was not significant. But everybody asks us, why do you have so much chronic lung disease in babies between 32 and 27 weeks? And we did our study, and what we found that is in Bogota, 2,600 meters above sea level, incidence of chronic lung disease with the definition of 36 weeks post-conceptional age, 50%, 52%. In the other cities where we did it, it was only 12 and 13%. So in our situation was different because we were comparing, again, we used centers with different altitudes, and that would make this look more higher. But in the centers that were at close to sea level, it was just the same as it was here in the United States or in Europe. And where we did find a difference in chronic lung disease, and we were not surprised now, is that we found it in the bigger babies, the 30 to 32 weeks gestation babies. That's the population where we did find a decrease in chronic lung disease. Why not in this population? Well, we have an explanation. These babies, when they develop chronic lung disease, they have more lung arrest. There's a different phase of lung development for these babies. And so surfactant alone can decrease it. And of course, CPAP, which is more protective for the lung, could do it. That's why we think that the ideal study at this point in time would be a randomized control trial where you gave surfactant in the first hour of life to babies with respiratory distress and then randomize them to mechanical ventilation or to CPAP. That's the right study that should be done that has not been done. The study that we did, comparing the CPAP with and without surfactant, should have been the study that was done in 1989 when it was done with mechanical ventilation. And so at least now we can say we've put that into the literature and that little gap is filled. But now we have to do a new trial. And this is the trial that we're waiting people to do that have the motivation to go forward with that. For failures, these are our rescue surfactants. We also found that failures on CPAP, which is correlated with the need for a second dose. Anybody who had a second dose had to be intubated on mechanical ventilation. 12% in those that had surfactant, 25% in those that did not get. So if you don't give those babies surfactant, their failure rate is much higher, even with those criteria that we use that are pretty high, requiring 75% oxygen. So again, surfactant, very good. This we did just to compare the control groups and the differences between that and that incidence of 9%. So in premature infants treated with nasal CPAP, and I'll end here, immediately after birth, very early surfactant therapy without mandatory ventilation decreases the need for subsequent mechanical ventilation. Rescue surfactant doses and the incidence of air leak syndrome. At least we can say that with that information. I'm just going to show you this slide. just to tell you that, again, don't compare apples to oranges. So we've talked about the CPAP trial here in Europe, the COIN, the support, and this is the Colombian Neonatal Research Network trial, the one that I just showed you. And important to show you that here, when you look at the populations that were included, they're very different. This population is different from this one, from this one, from this one. These are more similar. But the way the interventions were applied were very different. These two trials, the CPAP and support trial, were prophylactic trials. These babies, their criteria was to meet the gestational age. So if in the post-prenatal steroid era, we're now recommending, yes, not all babies are going to require intubation, CPAP, or mechanical ventilation or surfactant, because their exposure to prenatal steroids might have a baby that does very well from a lung perspective. All those babies were being exposed to these interventions. And there had been a study that we looked at prior to this, a prophylactic CPAP, that showed the worst outcome in babies when it was given prophylactic, more complications. And so this study, the COIN study, the only thing that we can compare it with that Colombian study are their control groups, which were similar, but we couldn't compare the intervention groups. The numbers, of course, again, having a larger or smaller study is not as important as looking at how the questions were asked and the methodology, and then comparing methodologies to be able to compare apples with apples and oranges with oranges. Okay, that's the end. So if you have any questions, I just put this thing here for recommendations, what we're doing now. Evaluate infants with 27 to 32 weeks gestation for evidence of respiratory distress in the delivery room after initial resuscitation. If no evidence of respiratory distress, observe. If evidence of respiratory distress, place on nasal CPAP and give very early surfactant within the first hour of life. Central lines only necessary with moderate to severe respiratory distress and progressive increased work of breathing. We eliminated that. In all these units that participated in this trial, they used mechanical ventilation as a rescue therapy, and they seldom put lines in babies, when in the past, before that trial, they were all putting lines on these premature babies. And administer prophylactic methylxanthines. That's something I didn't tell you. To all our babies, we did use prophylaxis with methylxanthines because we did not want to have failure secondary to apnea, which the other studies did not use. And so that's something that even with the new information on the randomized control trial with caffeine that shows better development, decreased lung disease, we're using it now more prophylactic for all our premature babies. And set clearly defined criteria for treatment failure on nasal CPAP and follow those criteria. They're intensive care babies, and so they need more observation, of course, very close observation. It's not like when you put the babies on the ventilator, give them the surfactant, and then you go do your other things. With babies on CPAP, you have to be on top of those babies. And that's the lesson that we learned from Dr. Tien Young at Columbia Presbyterian, that if you want to have success on CPAP, you really have to be on top of those babies, looking at them and seeing what's going on. That's his success, his individual participation in the care of all these babies. Thank you very much. Questions? Yes?
I'm just wondering sort of about the follow-up regarding those patients, for instance, a 27-weeker treated with early surfactant, for instance, 12 or 6 hours incubation and then extubation to CPAP. And then in the follow-up, initially the patient was on 21% of oxygen, and then in the curves increasing needs for oxygen up to 40%. And on the X-ray you see like more pulmonary edema picture. And I was working on different units, and the one unit was very liberal with diuretics, and the unit I'm working on now is sort of very restrictive with diuretics. And the unit sort of with the liberal diuretics management, we didn't see those pictures with the need of increasing oxygen up to 35%. And the unit I'm working on now, I quite often see the pictures of sort of this pulmonary edema, increasing need for oxygen, and yeah, we always sort of have this discussion about what to do with those kids.
Yeah, we didn't use diuretics on these patients with respiratory distress syndrome, but I've been in places in which where they use them. What do you use? They use furosemide?
No, the hydrochlor and
Hydrochlorothiazide, which is a more gentle diuretic. Yes, I think that's something that should be looked at
I mean,
prospectively.
yeah, I think it's a sort of example for experience and evidence. I mean, the literature say no evidence for diuretics in BPD. But yeah, I think it's sort of quite difficult to answer.
Yes, we tend to use, once we start getting into dependency on mechanical ventilation and on CPAP inclusive, we start thinking about the diuretics, but as an afterthought, later on during the second, third week of life. But we've never thought of really doing it earlier than that. And we abused a lot on ventilation, the use of furosemide, and we produce a lot of rickets in our patients. And I think that we were very shy to do it very early on, but I don't think that would be something to look at prospectively if diuretics could shorten the course of the disease with respiratory distress. In these babies in this trial, we did not use diuretics. We just, the methylxanthines and just that surfactant and early versus non, but no other intervention. But our neonatologists after that trial, they're very happy because the cost of care has decreased significantly. They can now focus on what ventilators they want, but they don't want quantity because they know that they can manage the 2/3 of their babies with the CPAP system. And they're also happy because they're having less infections and with less use of central lines. Every single baby used to have them.
One other question, if you have like secondary respiratory failure, so the baby needs to be intubated on whatever, day 3 or 4, and you already started caffeine on day 1. And then my opinion is usually sort of to continue the caffeine even though if they are intubated. But there are sort of different policies, sometimes they sort of
in the past we would get physically hurt if we left the baby on the methylxanthines on the ventilator, and we would have all this, our professors would tell me, what are you thinking of? Why are you giving these babies caffeine? I think that caffeine trial, Dr. Schmidt's trial, was very important because it just emphasized something that we intuitively understood, that babies are premature babies, and extreme premature babies are going to have apneas. And if they're going to have apneas, they're going to have desaturations. And if you're frequently having desaturations, something's going to go bad with that. And developmental outcome was very important. We were concerned because we suspected that developmental outcome would be what would be different between the two groups. And so if you can decrease apnea, and you can have apnea on a ventilator also. But there were other advantages to that, and decrease in chronic lung disease, which we're trying to explain why. We think that all those factors that they found in that study suggest that you can give it, and we don't stop it now that when the babies are on the ventilators. We have data to support us keeping the babies on the methylxanthines, but we don't take them off.
Mario, can I ask you a question? You demonstrated really beautifully how difficult it is to do the right trials to address these issues. And my feeling over the last 15, 20 years is that people have gradually taken these messages on board, that we need to reduce barotrauma, that there's a proportion of very small babies that we probably never need to intubate and we can manage with CPAP. But the fact is we have these very high rates of BPD. And I ought to know the answer to this, but I think it's going to be very difficult to do the right trials and get clear answers that are translatable into ordinary routine practice in hundreds of units around the world. And I actually was interested in you probably know, or Sandra knows, what the trends are with BPD rates over the last 5, 10 years or so from big databases like Vermont, Oxford, because I don't know. And I should do, but I don't, what is actually happening. Because, it's going to be difficult to do definitive trials. And I would hope that as we understand these problems more and hopefully do things a bit better, we might see change. And I'm not conscious that we are seeing any change and reduction in BPD rates. I know it's a very complex disorder, but I don't know if you know what the situation is in big databases.
I think that because we've moved down to the extremely premature babies.
But we ought to be able to look at the population 26 to 28. I mean, it's sort of, if we could sort it out for the 26 to 28, 29 weeker, that would be a great step forward.
I don't think we have seen a decrease in that population. And it's because of all the multifactorial aspect of chronic lung disease. It's not one thing, but there are multiple risk factors that come together to produce that. And because we're working with a much more immature population, we haven't seen those effects that we expected to see with the surfactant. And we haven't, and again, that trial where I'm talking to you that has not been done with comparing, taking mechanical ventilation out of the picture, but keeping surfactant as the primary treatment, that has not been done. I would hope that a trial like that could show that there is a significant difference in chronic lung disease between those. But again, we've not done that.
Part of it, I think, has to do with the definition.
Well,
Yes.
Yeah. I think if you look at the neonatal network base studies, the Stallman paper, Penn's papers, I don't think BPD is changing. But I think just experiencing it as, on the front, on the clinical front, I think the nature of the BPD is changing. Like when I was a resident and fellow, we had a room full of ventilator dependent.
That's a very interesting point,
and now they have a little bit of nasal cannula every 6 weeks.
And they go home on.
And they may or may not go home on it at term corrected. So I think there's a shift.
That's very interesting, isn't it? It emphasises how much we need longer term outcomes for these babies.
Or like what's a clinically, to me it's very significant if you need a trach and you go home on a ventilator or you sit in the hospital for an extra year on a ventilator. You don't see those very often.
No, that's
And we
interesting.
used to see them all the time.
And what we're seeing more now is pulmonary hypertension associated to chronic lung disease. And I think it has to do with the care of these extremely low birth weight infants that have rest in lung development.
Sure.
And so that we had to create a clinic now in our department, which cardiology runs, where these babies that we've been diagnosing, because we used to send them home without doing echocardiograms. We began to do the echocardiograms, we began to diagnose even more pulmonary hypertension. The nature has changed. And so a lot of these babies are going home on sildenafil, and their prognosis isn't a good prognosis.
Because that's such a well-proven therapy. Sorry.
The mortality is
We
high.
all do it, I'm sure, occasionally.
Yes, but the mortality is high, and we don't know these oxygen saturations that we're talking about, because I think that you had asked me that question about why the higher saturations in babies. Well, one of the things that came out of there is that we think that we were not, in the babies that were developing chronic lung disease, we were not giving them sufficient amount of oxygen because of our limits, and those babies are the ones that are developing more severe pulmonary hypertension associated with chronic lung disease. But we don't know that, but we're concerned about that.
Yeah, it's the oxygen side of things. I don't know how you manage your oxygen sats and what's okay at in Colombia and Bogota when you're at altitude. And the general population will be running different sats, and should you increase your hemoglobins, and then your sats will be slightly different. And
In Colombia, it was normal for them to have 85 to 88.
Yeah, that's right, and it's just a real issue. We've moved to the highest saturation range because we are concerned about the results from the. And when you're looking, we use TCM monitoring a lot, plus invasive oxygen monitoring, and you can see some of those sats are acceptable, but the PO2s are really, really low. And we go back to where we were with the unable to get the sats up in babies pre-surfactant. I've come from that era, and the developmental outcome was awful, but it was probably because we just couldn't maintain it. So I find it difficult to say we should ignore the study, we can criticise the most recent study, but we have moved our SATs up. I just wanted to say that. I don't know where you balance saturation to, okay, we're forgetting CO2s, then you've got the equation of the acidosis, and you've got the equation now of hyperalimentation with the babies. Are they okay with this level of acidosis? That's the sort of equation. We're tracking lactates a lot more now, and I don't know if there's any evidence for that too, to say this is okay, but you know, I don't know where we go with. I can see the need for the trials in terms of ventilation, but then I say, you know, we're still looking at, should we have this level of SATs? Ignore them. Lungs might be a much better outcome. What's the brain, you know?
So I guess what we have is a lot of questions that we need to look at and try to answer the right way, and that's the stimulating part of it. This doesn't end, but all these different variables, and just think about the concept of the fish oil and how that might change chronic lung disease.
Yeah.
And if you add those factors, what is it that we can do to these new babies to make a difference in that outcome? I think that there's a lot of research that can be done.
I think there's a trend in using more non-invasive ventilation. Do you think that's a good idea in this perspective, or?
Yeah, so with the non-invasive ventilation, there's all these technology that's coming out faster than we can digest it. And so we had an apparatus that appeared in our unit that was called Vapotherm. Does anybody use that?
Yes.
Okay. And then suddenly they were using flows of 8 liters per minute.
Absolutely. It's just giving another way of being CPAP.
And so we were saying, well, does anybody study what does that correspond to? Because the apparatus is not labeled for use in babies with respiratory distress syndrome. But we use it to simulate CPAP because of the discomfort in the nasal, in the prongs, and so now the nasal cannula is better. But when you ask somebody, well, you're giving 8 of flow, it's non-invasive, but how much did that translate in a PEEP? What PEEP are you giving this? We don't know. In 6, we don't know. So some babies do good with it, and some babies do not. And so a lot of technology is being sold with that, but now that you're having the intermittent SIV given with the CPAP. A problem with that technology is that it's not synchronized. Now they're trying to synchronize it because we're doing the same thing as when we were giving mechanical ventilation without synchronization. So you have a baby breathing spontaneously, but you give the baby a breath that is not synchronized with inspiration. And does that have any effect, or is that going to make the baby more uncomfortable? And so now they're trying to get, you know, what is novel and I think is coming up is how you give the surfactant. So I just looked at a study where they put a laryngeal mask. Everybody know what the laryngeal mask is? And they gave the surfactant through the laryngeal mask. And then they looked at parameters and showed that there was improvement in lung compliance. But they didn't do it appropriately. I think they needed to tag the surfactant with technesium and then give it and then be able to see how much goes into the lung and how much goes into the stomach. And so that paper needs to come out. But they've tried to do surfactant by inhalation. Again, not done appropriately. There's a product out there, but I think they need to tag that and also quantify how much goes into the lung, if it's efficient or not. But I think the technology is going in that sense to give that surfactant earlier in different ways that are not as invasive. People are afraid of intubation, of course, but when you have a baby with RDS, the best way we have it is through intubation and giving it surfactant. As I mentioned, whether you're going to do mechanical ventilation or CPAP, you have to intubate to give the surfactant. Maybe we'll find out that just doing the laryngeal mask is good enough, and then we don't have to do the intubation. But I think that that's where we're headed to. With the other apparatus, I would just warn people to not invest their money in them. There's more science that needs to be looked at that to determine really if it's safe and how much does CPAP, how much pressure you're going to give to these babies, and what are the alarm systems in them, if they're appropriate or not, because you can increase significantly pressures. Yes.
Yes.
Otherwise, we will